Welcome everyone for our monthly session of LEJEndo, that is like an international journal club focused on endometriosis. I'm here with the LEJEndo team. So just to introduce the people that are present, we have Mikey Adamczyk, that is a consultant gynecologist working at Ashford and St. Peter with the CMIG and also in London with the CMIG London with Oscar Barnick that has just recently joined the team and is a post-CCT fellow with Shane Casali and Mikey at the CMIC London. Kyle Fleischer, that was a previous fellow with CMIC London, and now has joined the CMIC in St. Peter to finish his training. With Flo Britton, that has just stepped down as a CMIC London fellow, and she's in St. Peter as well. And then we have also Karina Hansen that is kindly joining us today as she's going to be our feature article. And yeah, I'm really looking forward to hear her paper. I can actually already introduce you, Karina, while I started. But Karina is a clinical psychologist that works in Denmark and has a really big experience on endometriosis. She's done a PhD with more than 20 publications on endometriosis field, and she's very involved both on research on the clinical aspect of this pathology, and really our focus is a psychological intervention that aim to improve the quality of life with patients with this disease. And this is actually the focus of our paper. Psychological intervention and improvement on quality of life with patients affected by pain due to endometriosis. She also was part of a EU Horizon 2020 and the project that probably many of you have heard, the Female Project. And currently, I think you have started a new adventure in Denmark and you started your private practice as well. So best of luck. There is also Avril Baci that just joined us, that is actually finishing a training with me in Guildford, and soon will look for a job. And yeah, she's great. Then Shane Casali will join us soon, probably in the next 15-20 minutes. I just want to say thank you to Carl Storz as well, that is supporting us, running these webinars with the advertisement and everything really. And this all webinars is done in collaboration with the European Endometriosis League. We're going to start with a couple of papers that are going to be presented by Oscar and Kyle. We try to find papers that are focused on endometriosis, and we always don't agree with the papers, but are papers that we think are worth presenting. What do you have for us, Oscar?
Yeah, we've got Kyle speaking first.
Kyle
So
first.
go for it, Kyle.
Yeah, so first up, this study was published by a group from Switzerland, and it focused on the coexistence of endometriosis in those with uterine malformations. So just moving to the key points, this study analysed data from over 1,500 cases with histologically confirmed endometriosis over a 15-year period. The researchers aim to clarify whether those living with endometriosis have a higher prevalence of congenital uterine anomalies and malformations, and whether these structural anomalies impact disease severity. Overall, these anomalies were diagnosed in 5.9% of patients with endometriosis, which is comparable to the general population, and the most frequent types included arcuate uteruses, partial septates, and complete bicorporeal uteri. Interestingly, in the study, women with anomalies were significantly more likely to have stage 4 endometriosis via the RASRM classification and report more significant symptoms of dysmenorrhea. However, there were no significant differences in rates of dyspareunia, dyschezia, or subfertility. The study was limited by its retrospective design and selection bias, with many individuals referred for subfertility reasons. Additionally, reliance on 2D ultrasound rather than 3D or MRI may have underdiagnosed some anomalies. So this summary of the study design. So as mentioned, essentially individuals with histologically confirmed endometriosis on laparoscopy anyone that had a visual diagnosis without histological confirmation was excluded. The classification uses the combination Escher-Esky system for uterine classifications, and endometriosis was staged according to, or classified, I should say, according to RSRM and hashtag Enzian classification. Endometriosis, deep disease was defined as anything that was infiltrating beneath the peritoneal layer at laparoscopy. So with a deeper dive into the results, the key takeaway is that anomalies don't appear to increase the likelihood of developing endometriosis, although they may be linked with more severe forms of the disease. Individuals with anomalies had significantly higher rates of RASRM stage 4 disease and prevalence of deep endometriosis, particularly in those in the uterosacral ligaments and pelvic sidewall, according to Enzian classification. We also mentioned about an increased likelihood of dysmenorrhea. The bar graph shows that 38.9% of those with both conditions had stage 4 disease, compared with only 28% in those with a normal uterus. The authors conclude that this supports the notion that while CUAs may not be causative, they might exacerbate disease severity, possibly due to altered uterine peristalsis, retrograde bleeding, or associated adenomyosis. With regards to retrograde menstruation, because of the small number of obstructive anomalies in this cohort, they did not feel they could draw conclusions here. Overall, it's an interesting study and a well thought out study. I think the authors worked very hard to negotiate essentially their variables. However, further work needs to be done to ensure, are we getting the true prevalence of anomalies, and further analysis of obstructive anomalies are needed to assess if prevalence is actually higher in this group.
That's interesting. You know what I actually was thinking? I don't know if you were thinking the same, Mikey, but with all the patients where we see with pelvic pain, I don't think I see 5% plus of uterine anomalies in our patients.
So the
sounds
thing
quite
to
a lot.
say about that, Ben, is that they classified even a arcuate or a dysmorphic uterus as an anomaly.
Yeah.
So something that I'm not saying you could argue could be on the range of normal, but it's certainly anomalies are on a spectrum of severity.
Yeah.
But even anyone with an arcuate uterus came under a category of having an anomaly.
Yeah.
And how many of them had diagnosis of adeno at the same time?
I do not know. I need to go back and look.
It is an interesting study. The one way of looking at it is if patients with uterine anomalies, well, essentially it's just sometimes the first thing that you'll pick up, right? When you're scanning someone and you pick up a uterine anomaly. And I guess it's just worth thinking that 40 or 38.9% of them could have some colorectal disease or deeper disease in the pelvis that might require potentially an MRI scan. So yeah, interesting study. I like it. Good. What else do we have, guys?
Go for it, most.
So the next paper is a paper on pain reduction using an immersive digital therapeutic tool in women living with endometriosis-related pelvic pain from a team in Bordeaux in France. They were interested in the idea of a VR-based tool, so virtual reality-based tool, to improve pain relief in women who weren't improving with other techniques that we're familiar with, hormonal and surgical. And it was an RCT designed for home use, trying to target pain modulation in those with endometriosis-related pelvic pain. So they used a randomized controlled trial of 102 women, and the intervention was an 8-minute long immersive VR experience, which they named EndoCare, which they compared against a control of the same application based, but in a 2D control app on a tablet instead, as seen in the photo. They did an 8-week duration of home-based treatment and looked at primary outcomes in the change in numeric rating scale for pain intensity at 8 weeks, and also secondary outcomes of quality of life, sleep, mental well-being, among other things. In terms of the results, they had a mean pain reduction at 8 weeks of 1.8 versus 0.6 in the control, and that was statistically significant. And 74% of the virtual reality users achieved more than a 30% pain reduction, and that was versus 26% in the control. There was improvements noted in quality of life and sleep scores, although these weren't statistically significant. And as you can imagine, no one experienced any adverse effects from watching these two platforms. The conclusion from the authors would be that immersive VR digital therapeutics could significantly reduce endometriosis associated pain. It's clearly really accessible once you've got the tech to actually lend out to patients, or ideally, obviously, patients having themselves, and they're developing this as a application for pain-related control. And then it's certainly non-invasive and really well tolerated. And the sort of future integration of digital therapeutics as part of the wider MDT care could be something that goes on to be really useful as it becomes more and more accessible. Obviously, it's quite a small study, and the comparison was interesting between the 3D and the 2D. They had immersive headphones for the 3D with slightly different audio, and it's that whole component that really looks at trying to rejig the way the brain is feeling that chronic pelvic pain. And that's something that hopefully gets further developed as well. So I think it's quite an interesting way of helping women with pain that isn't just hormonal or surgical.
Can I jump in here, Katrina? What do you think of this? I think you are the right person to actually address that, right? What do you think of studies like that, and this type of sort of treatment for patients with pain?
I think it's really interesting, and I think this is just one of the ways to illustrate that pain is an experience, and that we can influence this experience in different ways. I'm interested in, do they say anything about what they think are the working mechanisms of this intervention?
They don't really delve into that. They're mostly looking at just the difference between the 2D and the 3D. But they mention things about the particularly immersive nature of the audio releasing slightly different sort of maybe releasing different neurotransmitters and things in the brain. Certainly the calming nature, but they looked very closely at the pain-related scores sort of in the very short term after the treatment, within the first sort of 20, 30, 60 and 120 minutes, and then longer at that 8-week pain reduction. And they could see quite clearly that the pain reduced almost instantly after watching, and then it stayed reduced during the number of hours afterwards. So it certainly looks like something that could be really useful, considering how easy it may be to use once you've got the tech.
It is super interesting. And I completely agree with you, especially when you said that pain is not the pathology. I've got the same point of view that pain is essentially the information that travels to the brain. It doesn't mean that there's that pain essentially is not a pathology itself. And I think we both on the same page with that. Does anyone want to add anything else to the last paper? No?
No, I think we can move to Karina paper if you're all happy. And
Yeah.
by the way, if anyone has any question, please feel free to write them in the chat.
So Karina, I'm hoping you should be able to now share. Here we go.
I'm going to just really quickly chip in that the prevalence of adenomyosis in anomalies in that study was 33%. So very high.
So
Brilliant.
do you see like the presentation or the real?
We see a presentation only. It's not the presenter's view.
Perfect. So thank you for the invitation to present this study that we did a few years ago. It's always, I'm always very happy to getting a chance to spread the news about what supplementary treatments can do in endometriosis. So I have just a few disclosures. So we know that pain is a major problem in endometriosis. We know that there are different kinds of pain. And as a consequence, that endometriosis is found to have a negative impact on all aspects of a woman's life. Or put another way, in addition to pain, there is other associated consequences, biopsychosocial consequences, such as irritable bowel syndrome, infertility, fatigue. There's a negative impact on mental health, emotional well-being, and a higher risk of developing depression, anxiety, and stress. It also have a negative effect on social relationships with family, friends, partner, children, and it has a negative effect on intimate relationships, work-life, education, leisure, and sport. So another problem is that the treatment of pain in endometriosis for many women is best described as a medical merry-go-round. So pain treatment consists of hormonal treatment, surgery to remove endometriosal lesions, and pain medication. However, these treatments are associated with medical side effects. They can lead to repeat surgery, and recurrence of symptoms and development of chronic pain is frequent. So new intervention strategies are needed, and they have to be based on evidence. So we know, like I mentioned before, that the pain experience is influenced by, we know from neuroscience that it is influenced by previous pain experiences or our so-called pain history. It is also influenced by attention and our expectations of the pain. It is influenced by stress levels, by emotions, thoughts, and mood, like worrying, catastrophizing. It is also influenced by the social context and by brain plasticity. So to me, this seems very psychological and therefore leads to the question whether psychological interventions can improve pain and quality of life in women with endometriosis-related chronic pelvic pain. So therefore, we developed many years ago, actually, psychological intervention specifically for women with endometriosis. It was based on a combination of patient education, mindfulness-based stress reduction, which is an evidence-based program, and also acceptance and commitment therapy, which is also an evidence-based psychological intervention. And we started out with an observational pilot study to examine the effects of this mindfulness-based intervention. And we included 10 women with endometriosis-related chronic pelvic pain who received 10 sessions of mindfulness-based intervention. So the results of the study indicated positive and significant effects on endometriosis-related quality of life measured by the endometriosis health profile, even at 6 years follow-up. And in this case, lower values indicate better quality of life. So this meant that there was a good argument to do a larger study, a randomized controlled study to examine the effects of this program. However, because the study did not include an inactive control condition, we do not know whether participant improvement was just a picture of the natural history of endometriosis, since pain fluctuates over time, even in untreated chronic pain patients. And because the study did not include an active control condition, we do not know whether patient improvement was due to the specific mindfulness ingredients of this intervention, or whether it was due to the more non-specific factors of psychological interventions. So therefore, in order to answer these two research questions, we had to improve the design of this study. So the research questions were: do psychological interventions improve pain and quality of life in women with endometriosis-related chronic pelvic pain? And is the mindfulness and acceptance-based intervention superior to a matched non-specific psychological intervention? And yeah, to examine this in a 3-arm randomized controlled study. So we started with the design of a matched non-specific control condition. It was designed by scrutinizing the mindfulness manual in order to determine what was the specific ingredients that had to be removed in the non-specific treatment. And in addition, we added a placebo or a matched activity to the non-specific intervention in order to control for the specific mindfulness ingredients. And this resulted in the following. So both interventions consisted of psychoeducation and group therapy. So the control for guided mindfulness meditation was relaxation, listening to soft music. And as a control for yoga exercises, we added training exercises to the non-specific intervention. So also the materials were matched in detail. Both groups received the same booklet about endometriosis. The mindfulness booklet was matched with a non-specific booklet, and yoga cards were matched with training cards. Guided meditations were matched with listening to musical music, and both groups received the same amount of home practice. So I don't think this has been seen in a study of psychological interventions before, that we have done such a match between a placebo match to the specific ingredients. And this is just to demonstrate in the picture that we actually also matched the layout of the booklets in the two groups closely. So both interventions consisted of 10 sessions of psychological face-to-face group intervention, and they were delivered by trained psychologists. So in order to try to balance potential therapist effects, we know from studies of psychological treatments that the relation to the therapist can be an ingredient or in itself. So in order to balance these potential effects, we chose a crossed therapist design where both therapists were trained to manage both interventions. And 135 women were found eligible for screening. However, 27 did not return contact and 50 were excluded for different reasons. So the inclusion criteria was they had to have a diagnosis of endometriosis from either surgery or MRI, and they had to have a pain score of a minimum of 5 on a numeric rating scale. And 58 of the women met the inclusion criteria. And 42 completed the study, with 14 women in the mindfulness and acceptance group, 15 women in the non-specific group, and 13 women in the waitlist group. Even though there was a lot of participants in the beginning, we ended up with the 42. Participants rated chronic pelvic pain intensity and pain unpleasantness on a numeric rating scale in a daily diary for a period of 12 weeks. So that included 84 measurements. And quality of life was measured with the endometriosis health profile before and after the intervention. And the intervention was for 10 weeks. So in order to answer the first research question, we compared psychological intervention to the waiting list. And in this study, in psychological intervention is defined as the two active interventions together compared to the waiting list. So this is a graph demonstrating the development of chronic pelvic pain over the 12 weeks for the waiting list, which is the blue line, and for the psychological intervention, which is the red line. And the results of the data analysis indicated that psychological intervention was not effective for pain relief compared to the waiting list. However, the graph for quality of life indicated something different. This is where the lowest scores indicate better quality of life, and we see the red line indicates an increase in quality of life for psychological intervention, whereas the blue line indicates no difference over time for the waiting list. Yes. So we did see, so psychological intervention was effective for improvement of quality of life compared to the waiting list with the medium to large effect sizes in 3 out of the 5 subscales of the endometriosis health profile. And in addition, we also found significant effects on endometriosis-related symptoms, constipation and dyschezia. And we found only pre-post effects on fatigue, workability, and pain acceptance, probably due to the low amount of participants. So, in order to answer the second research question, we also compared the mindfulness and acceptance-based intervention to the non-specific intervention. And this graph shows that there was that mindfulness and acceptance-based intervention was not superior for pain relief compared to the matched non-specific intervention. And the same was found for quality of life, that mindfulness was not superior for improving quality of life compared to the non-specific intervention. Yes, so the conclusion of the study is that psychological intervention may be effective for quality of life improvement in women with endometriosis-related chronic pelvic pain. However, it was not effective for pain relief. And we also found that mindfulness and acceptance-based intervention was not superior to a matched non-specific psychological intervention. So importantly, it is possible to improve quality of life and other symptoms and consequences of endometriosis despite persistent pelvic pain. And I don't know if I have a little more time. Can I add a little? Or
yes, of course. Go ahead.
Yeah, because a little has happened since that I would like to also share with you. So in order to make this treatment more feasible, we had a lot of participants not being able to participate because they didn't have enough of surplus or energy to participate in the study. They had to travel to meet up face to face. So in order to make this treatment more feasible and to get out more broadly to patients, we have decided to digitalize the program. So we changed and refined the program a little and ended up with 10 online sessions. This is the content of the patient education of each session. And every digital session consists of the same 3 elements. There is a part called patient education, a part called management strategies, and a part with the practical exercises like the yoga, guided yoga videos and guided mindfulness. So we invited patients in to co-create the program in order to be sure that they would also find it relevant. And we did a qualitative feasibility pilot to evaluate its relevance and importance. And what we got back from the participants was that they found this digital version important. It was important that it was disease specific and not just a generic program for pain or something, but that it was disease specific, endometriosis specific, because that improves understanding and recognition. And it gave them the feeling of being part of the community. It gave them hope for the future, It helped managing difficult thoughts and feelings in relation to the disease. It gave feelings of acceptance, confidence, and control. It helped managing both physical and bodily symptoms. And they also felt that they learned practical exercises, or they were getting a toolbox with practical exercises that they can use. So this was also published very recently. And the next thing that we wanted to examine was, of course, whether a psychologist is needed when you do a digital program, or whether a participant can just complete the program in a self-guided version. So we actually did a pilot study, but I can't present the results of that pilot study yet. So that's a little teaser. So that was all from me. Thank you.
Thank you so much.
Yeah, go on, Ben, go on.
No. Go. What did you want to ask, Mikey? Go
No.
for it.
I was just going to ask Katrina, thank you for the presentation. The online version that you have, I presume this is only in Danish, or is it in English as well?
It is only in Danish.
Okay.
Yeah. Yeah.
Go on, Ben.
I wanted to ask the same, actually. Like,
yeah, but I could say I can say a little about. Well, we found out that the self-guided version was not feasible without therapist guidance. We actually don't have data on the effects of the program because people in the self-guided group dropped out.
Okay.
Yeah.
Okay.
So luckily, I still have a job.
Yeah, good. And Katrina, maybe tell us. Hi, Shaheen.
Hi.
How are you?
I'm good. Sorry, I'm late. Yeah, I was listening to the second half, although I've heard some of it previously. I like the mug, Mikey.
Yeah.
So yes, go on. Don't let me interrupt. I do want to ask a couple of questions later, but go on.
Okay. Katrina, maybe tell us a little bit, how does the system works in Scandinavia? So for patients that are operated within the national healthcare system, do they automatically see a psychologist if they want to, or is it quite similar to what we have in the UK? How does that work?
I think it's quite similar, even though I'm not sure how it is in the UK. But in Denmark, you don't have access to a psychologist.
Okay.
There is not very good options for supplemental treatments. No,
Mhm.
you have to pay for that yourself.
So you sort of have to go privately in order to get that support. Yeah, that's very similar, unfortunately, to what we have here. And I do personally believe very much in the psychology, and I think it's very useful for some patients. Okay. Does anyone have any questions? Do we have actually any questions from the chat? Did anyone have a
We
look?
have one question on the chat, Mikey.
Go on, tell us, Oscar.
This is from Marco Zakaria. Dear Dr. Hansen, thanks a lot for your great presentation. What do you think about the use of minimally invasive radiofrequency surgery techniques to treat pain, subject to in-depth study with neuropelviology? I'm thinking, for example, of uterosacral ligament ablation under ultrasound guidance with an endovaginal probe as a control. I'm not sure if, by the look on your face, this might not be quite aimed at the right person.
No, I think there's someone here who can better answer that question than I can.
Shaheen, what do you think?
I don't know enough about it. I am not aware of the evidence around it. We know that similar surgical procedures have been now conclusively ruled out as being ineffective. So Luna, for example, is one of the procedures that has quite good evidence of ineffectiveness, if you like, and therefore, as a matter of principle, killing nerves is not the treatment for treating pain. But I do think more relevant to the talk, I think I am personally understanding more and more about the value of psychological input and treatments. You know, we always talk about it. I think this is important to mention that. Okay, it has become like cliche that we say no multidisciplinary input, psychological treatment is important, but do we really understand that? And I think from my trip to Stockholm, it was another reason for me um, to realize that actually we need to take psychological treatment really seriously, and having a mental health professional is really valuable, not only because it makes what we do more effective, but also a lot of the time it may avoid surgery, it may help patients not undergo unnecessary procedures, and I really now truly believe that it's really important. I don't know what the others from the audience or you guys have felt or seen from experience, but I really think that this is one thing that we are missing.
Uh, I think you make a all very good point, Shane. The only question that I have then for you or for everyone else, how would you implement it though, like practically in a practice, considering the number of patients that we see, like I don't know, like for example in the NHS I see like 18 patients to 20 patients a week. Uh, do you know what I mean? Like if we do it before or giving option for surgery, or only to the ones after they don't improve?
So I tell you what my experience has been. First of all, I was surprised to see how open patients are to the suggestion that, we can't just be looking after your physical health. You are a person, and the pain, particularly, is not something that is like a gallbladder stone that you go and remove endometriosis and everything is sorted. And patients are open to it. I was always worried, maybe up until, I don't know, 3, 4 years ago, that if you mention mental health to patients, they think you're dismissing their endometriosis, or they think you're saying it's in their head. But if you take maybe just 5 minutes to explain to the patient that, number one, I completely believe what your pain is and validate their pain, do acknowledge that surgery may be a very important step to treatment. So we're not arguing with any of that, but we are going to have a much better outcome if we look after you as a whole instead of seeing you as endometriotic nodule with a bit of person around it. It's really important that we really get that across to patients. That has been my experience. I don't know what others think.
I think there's also two ways to use psychology in this. We can use psychological treatments for the mental health part, or the consequences that the pain affects the whole person, and there might be some anxiety or depression and stress that need to be managed and treated too. But there's also the part where psychology can influence pain, and it can influence the effect of other treatments. You just said it before, that we can use expectations and attention and other psychological aspects to enhance the effect of an already given treatment. And there are some studies from placebo and open label placebo research that shows that it can also be used to enhance other treatments.
Yeah. What has been your experience, Karina? So you probably know this better than we do, that because for years patients with endometriosis have been truly dismissed and maybe not looked after properly. And when people didn't know what to do with them, they would send them to the psychologist. It has become a very sensitive subject for everyone. Okay. What is your suggestion? What do you think works best to bring patient on board to accept psychological input and not see it as dismissal by the surgeon, by the endometriosis specialist?
Well, I think it's so important that the validation part, that I know that this is not something that is just going on in your head, that I know that this is a real experience to you. The pain is a real experience, and I use very much patient education about the nervous system, the autonomic nervous system, and brain plasticity, and how we can give new inputs to transform this experience. I don't know if that was an answer to your question.
Yes, yes. And what do you do with them? Let's say, Mikkel has sent you one of his patients who has had, let's say, multiple procedures. She did have endometriosis. Now it has been excised, but she's in a lot of pain, and he asks for your help. What do you actually do with them? How many sessions do you need with them? And what do you do during those sessions?
I just share again my PowerPoint, because this one, because I ask the patient, what is your biggest problem right now? Is it endometriosis? Because what psychology can do is we can move our attention away from the disease, where you have tried everything you could come up with, from surgery and medication, etc. And maybe there's not more to do with endometriosis, but we can focus on all the other aspects. So I always ask, what is your biggest problem? And often when people, or when women come, pain is no longer the biggest problem. Many say, I've actually learned to live with that. But now fatigue is my biggest problem. I don't have energy to participate in my work life or my education or being with friends, and then I start getting insecure and depressed, and maybe even anxious with if this will ever be better, and so on. So we use this flower, you can call it, and then we dig or dive into what is the biggest problem of the women who come to me, and we work from there. And often it is not directly on the pain, but what the pain hinders me from doing.
I see. I see. Okay. Well, thank you very much, Karina. Mikey, are you chairing?
I was chatting.
Oh, you were chairing, Ben.
Yes.
Okay. So I'm going to be a listener, but I just wanted to personally thank Karina. I don't know if you guys said this, but I was in Stockholm, was it last week, a couple of weeks ago? And I listened to you talk, and I was having dinner with Mikkel the night before that, and he was singing your praises and was telling me how important your work is to what they were doing. And I am very grateful that you could fit us in and talk to us. I hope that we can have you back, and I hope that we can maybe have some collaboration.
Could be nice, of course.
Thank you very much, Karina.
Thank you.
Happy to be invited. Yeah.
Thank you so much. If you want to stay with us, Karina, we are going to present two more of short papers before closing. Who is going to present the first one?
So I'm up next. So this was published by a group from the Netherlands. This was a multi-center comparative cohort study that was a follow-up 1 year comparing uterine artery embolization versus hysterectomy for symptomatic adenomyosis. So this was the Questa cohort study. It started as an RCT, but shifted to a prospective comparative design to improve its recruitment. It enrolled 101, 50 in the UAE arm and 51 in the hysterectomy arm, with quality of life measured over 1 year using various different validated questionnaires. Of note, both treatments improved quality of life meaningfully. In the per protocol analysis, UAE was neither non-inferior but also wasn't shown to be inferior to hysterectomy, and people who are aware of non-inferiority and inferiority and superiority, and they're sometimes a bit complex, but essentially one didn't appear to be better than the other in this context in the per protocol design. But in subgroup analysis, there were some small differences in certain quality of life questionnaires, specifically the SF-12, which favored hysterectomy. And again, pain improved with both groups, but there was a larger effect with hysterectomy, and satisfaction was higher with hysterectomy compared to UAE 95 versus 73%. You need to keep in mind the change in design of this study, as well as some of these tools, unlike the endometriosis health questionnaire, are not validated for adenomyosis specifically. That being said, there is limited evidence for UAE compared to hysterectomy and UAE in general in the treatment of adenomyosis, and we need to be mindful that a certain number of our people that we see in clinic will want to retain their uterus for various reasons. So just looking a bit deeper in the inclusion and inclusion focus on premenopausal individuals with MRI confirmed adenomyosis who are already candidates for hysterectomy and did not wish to conceive. Exclusions were standard for safety, as well as confounding factors, pregnancy, malignancy, infection, and conditions that would complicate UAE or mandate different surgeries. So, for example, individuals with deep endometriosis, and the investigators specify significant lesions infiltrating the bowel, or large myomas were excluded from this study. UAE followed a standardized protocol to complete, whilst hysterectomy was mostly minimally invasive. However, some were performed either vaginally or via an open approach, and there were even examples of supracervical hysterectomy as well. The primary endpoint was quality of life at 1 year, analysed by per protocol for non-inferiority with a 5-point margin, and corroborated with ITT sensitivity analyses. So looking at the results on the next slide, this forest plot shows the 52-week difference between UA and hysterectomy for quality of life domains. The dotted line marks the 5-point non-inferiority margin. You'll notice most estimates hover around 0 and across that line, which explains why non-inferiority was not demonstrated. That being said, pain outcomes favored hysterectomy.
Is it just me or is it Kyle?
I think it's connection, probably.
That weighs up the results from both. If you just move to the next slide on an infographic.
Kyle, do you mind just going back one slide and just repeat the slide of his results?
We've lost you there for a second. I think we've lost him again.
Yeah.
Authors publish an infographic with it summarizing their results.
Kyle, just maybe as a summary, can you just go through the results again?
Yeah, so
You froze.
Oh, sorry. So essentially, they couldn't demonstrate inferiority or non-inferiority, but I've indicated that that is complex.
Yeah.
Essentially, pain outcomes, there was a higher overall improvement in LH compared to uterine artery embolization, and overall patient satisfaction was higher in the hysterectomy group compared to the uterine artery embolization group. And that's all summarized in this final infographic. And I mentioned in the ACTA at Obstetrica Journal, it's really good. It's open source, and every article necessitates an infographic like this, which I always think is brilliant.
Can I ask something, Kyle? I don't know if you know.
Yeah, go ahead.
Do they do any distinctions between which type of adenomyosis, focal, diffuse?
So I'd need to look at the study protocol, but as far as I'm aware, no. Give me one.
No, don't worry if you don't know. We probably can go and read the paper. And I do wonder if during the hysterectomy they did some other procedures. Was there endometriosis?
So if there was mild endometriosis and simple, say adnexal components, they'd aim to do it at the same time. However, if there was deep endometriosis or anything that required colorectal resection, that was excluded, and that was aimed to be excluded preoperatively. So I can give you some numbers on, on the adenomyosis. Yes, they did try to differentiate between the groups, but they're comparable between groups, as in the percentage with diffuse, focal, combined diffuse and focal and unknown is similar between each intervention arm.
Okay.
Yeah.
Okay.
Shall we move with the last paper?
Yes, thank you. This is a relatively short paper assessing the effectiveness and safety of physical activity and exercise on women with endometriosis. It was a systematic review and meta-analysis, and again, very relevant with our guest speaker here today. As an introduction to the paper, they were looking at lifestyle and exercise interventions as being increasingly used to complement hormonal or surgical management, and it was aimed at assessing both pain and quality of life. They performed a systematic review and meta-analysis of 6 RCTs, including 251 women, and exercise modalities varied from aerobic to resistance-based, stretching, and Pilates-based interventions. Not all Pilates studios look quite as tidy as that. Duration was 8 to 24 weeks worth of treatment, and outcomes relatively were looked at as pelvic pain, dysmenorrhea, fatigue, and quality of life. In terms of the results, there was a pooled mean difference in pain intensity of -1.64 with a good confidence interval and statistically significant p-value. The quality of life improvement was moderate to large, and there were, as expected, no major adverse events reported across the included trials. I think something that was quite interesting was that the heterogeneity between the studies was low, 38%, yet the benefit was seen across the studies. And this may well suggest that there's quite a consistent benefit between the various modalities of intervention, and that not one bespoke type of exercise-based treatment is much better than the other. And in conclusion, to just round up this small paper, regular exercise in these different forms significantly improves pain and quality of life. It's obviously known to be safe and cost effective, and we know it has vast amounts of other health benefits too. And as Karina has obviously mentioned, integrating structured physical activity like they have in their yoga programs needs to start becoming part of our multidisciplinary treatment methods for patients with complex pain.
Okay.
Thank you.
Go, Ben.
No, nothing. I think like this whole Legendo, it seems that it was focused on Karina's paper, also with the last paper. Yeah.
Shaheen, do you have anything to add?
Well,
Do you
no,
want to
I
add
think, again, from my personal experience, not personal as in exercising myself, because as you can see, I don't exercise much, but patients who do regular exercise really do better. I don't know if that requires an RCT to show. I can't think of many conditions where regular exercise and yoga and mindfulness and or those kinds of interventions will not be useful or helpful and will increase the quality of life. And maybe that is especially true in endometriosis. But I think that validates what we do. Perhaps we should specifically tell our patients, maybe this is something that our specialist nurse can do more of in terms of health coaching when they talk to patients with endometriosis, to suggest that perhaps regular exercise should be part of their routine, whether or not they are having an operation or not.
That's a really good point. I do that routinely for my patients, I do have to say.
Yeah.
Big advocate for it.
What do you tell them?
What I tell them, it's usually sort of, I tell them that exercise is super important, especially in the recovery period. And I tell them to exercise 6 weeks after the surgery. I tell them to work a lot on core muscles and glute muscles. Okay. I tell them to usually go to a class rather than doing it yourself, because you have that slightly bigger push to exercise. I tell them that the first, like anything else, that the first couple of weeks or months are going to be quite hard, and then those pains or the residual sort of pains or the general feel they're gonna feel much better. And I suggest a lot of Pilates, body pump exercises, and core muscle training.
Yeah, makes a lot of sense. Well, wonderful. Thank you very much.